It's now my pleasure to introduce our next speaker to speak on, trauma-informed care in women's health. Our speaker is Dr. Nomi Levi-Carrick. Is that right? Levi-Carrick. She's the Vice Chair for Clinical Services in the Mass General Brigham Department of Psychiatry. She's an Assistant Professor of Psychiatry at Harvard Medical School and co-chair of the Brigham and Women's Hospital Trauma-Informed Care Learning Collaborative. She's also Medical Director of the Critical Illness Recovery Project and Associate Director of the Complex Diagnostic Clinic. She is recognized nationally for her work focusing on long-term outcomes following trauma, as well as innovative clinical programming integrating trauma-informed approaches to vertical integration of psychiatric services, as well as care of patients with high psychiatric risk and medical comorbidities. She served as mental health director of the World Trade Center Environmental Health Center from 2011 to 2015, and she worked with Doctors Without Borders prior to medical school at the Weill Medical College of Cornell University. She completed both psychiatry residency and CL fellowship at the NYU School of Medicine. Thank you. Let's welcome her.
Okay. Thank you so much for being here. We had this really extraordinary perspective shared by Dr. Nomi, and we want to sort of take this next hour to think about how do we take all of that and translate that into the healthcare system, into kind of meaningful individual interactions. I have no disclosures. And so over this time, we want to try and accomplish three things. One, identifying barriers to engagement in healthcare services for women who have experienced trauma, recognizing the difference between trauma-informed and trauma-focused care, and then discuss strategies for engaging trauma survivors in healthcare services. Ultimately, trauma-informed care is meant to be a resilience-focused frame, and we'll talk a little bit more about that as we go. I put some case examples to think about as we progress, just to help ground us a little bit. If you had a 42-year-old woman presenting with dizziness 2 days after reporting an accidental fall at home, if you had a 52-year-old woman presenting in DKA requiring ICU admission for stabilization, or a 60-year-old non-English speaking woman who presents with abdominal pain, how they're presenting, what their complaints are. We want to think about all of these and how to engage and get a good history in that process. So the first, let's identify some of the barriers to engagement in health services. For those in the room, we're quite sensitive to the fact that health is the sort of final common pathway. It sort of demonstrates many of the kind of root causes that drive, they're called the social determinants, but most of them are not social, right? They are structural, they are economic, and it's poverty, it's racism, it's all sorts of other structural barriers that can end up helping us understand how the person, the adult, and in this case, the menopausal woman in front of us, has come to where they are at that moment in time. I'd like to introduce also the social vulnerability scale. It's just a nice corollary. It was developed by the CDC at Oncology Care, but we have looked at it in the context of recovery from physical injury, and it has really, it's a helpful model, and it's something that you can kind of measure, and you can sort of see the different criteria. We sort of looked at the ways in which it showed the risks of PTSD, of new functional limitations, of pain, and there have been broader systematic reviews that have sort of demonstrated this. So just as you're trying to think about what are some of the markers that we can look at to understand, to sort of risk stratify a population, something else to keep in mind. So trauma, in physical trauma, we think about this injury. And with the trauma we're talking about today, we're also talking about emotional injury that occurs in the context of abuse or an accident or even a new medical diagnosis that overwhelms somebody's ability to cope, that shatters their sense of safety, that takes the locus of control, which we'll talk about, this sort of sense of a control in yourself and your destiny, and removes it from your sense of self. And people will spend a lot of time trying to figure out how to get that back, both with adaptive and maladaptive ways. But understanding that dynamic can be really helpful in understanding what's going on in the room. So there's individual trauma, and again, I would sort of say as people are addressing, all sorts of different violence, we know that that can be there, but illness is one as well. Sometimes for people who were healthy and now are presenting with a new diagnosis, or sometimes it's menopause symptoms themselves. That is, it feels like they are losing control over something that they thought they had agency around, and that can be quite scary. As people engage with the medical system, they have interpersonal impacts of whatever that is in their families, in their communities, and with their healthcare providers. Community matters. People have intersecting identities that impact this, and there's also all the structural factors. The fact is that most people don't just have an individual trauma. These traumas happen all with these kind of intersecting domains. And sort of recognizing that complexity and the multidimensionality, again, helps us to think about how we're going to address it in the room. Ubiquity of trauma exposures, I think after our speaker earlier, we don't necessarily need to spend too much time on this, but pick an audience anywhere in the world, and at least 2/3 of them have experienced some trauma. That you're much more likely to be right than wrong in assuming that somebody has survived trauma and adversity. A foundational study that was done in the US, published in 1998, was the Adverse Childhood Experiences Study. And I share that one because it was one of the first studies that demonstrated. So they took a large population, insured population, and they sent surveys asking about these 3 categories of adverse childhood experiences of abuse, neglect, and household challenges. And it was significant to see that nearly 2/3 of those surveyed had experienced at least one event. But it also showed a dose-response relationship, not just with mental health issues and with substance issues, which many expected, but also with chronic medical conditions. And this kind of work has been replicated in a variety of different chronic health conditions. And again, this one was kind of more recent, 25 US states, so over 63,000 people. And again, not just rates of depression and smoking and drinking and so forth, but also obesity, diabetes, stroke, asthma, COPD. And so people, as they're coming in to see us, those with the sort of greatest burden of chronic illness are ones that we should really be thinking about as having survived some adversity as well. So just a bit of a frame about trauma in women. While exposure to any traumatic event, and some studies show men, it's higher than women, but women are more likely to develop PTSD. Very kind of multifactorial dimensions around that. Outside the scope of the talk for now, but just to kind of keep that in mind. They're high impact events, and the exposures and the stress disorders are higher in lower resource environments. They're higher in minoritized populations. This is not an evenly distributed burden. And, women with maltreatment history and PTSD are likely, I just kind of wanted to raise that, to be re-traumatized around birth. And so that's one milestone that we want to sort of think about. What are people bringing into the birthing experience? What is that going to do in terms of bonding, in terms of navigating that post-delivery period? And the intergenerational transmission that kind of comes alongside that. There's really fascinating and important work. Nikki Bush is doing some work at UCSF that's really demonstrating this kind of intergenerational dimension of it. I highlight it here because these are the relationships that women have developed over time. And as they're coming in with menopause, they've got teenagers, they've got young adults. These are people who have an experience of trauma when their children are, each age presents a different set of challenges in engaging. And that is another thing to keep in mind because it impacts their sense of self-worth, their identity, the tone of the environment at home. You know, these are statistics that we've seen before. I think I sometimes leave this 13 to 61%. The way that we're counting it varies so much. Who's willing to report varies so much. The most recent study in women in the US, it's nearly 1 in 2 now. So despite all of our knowledge and our awareness, to Dr. Watanabe's point, it's somehow still increasing. The other important point is that sexual violence often starts early. Rape is happening in 80% of women before the age of 25. This has really important neurodevelopmental impact, what somebody's resources are, what their verbal capacities are, what their ability to reach out for help, what's going on when these things happen at an earlier age matters. And really these are sort of chilling numbers, and I will kind of reiterate what Dr. Watanabe said at the beginning. Please take care of yourself, and if this is the time to think about something else or walk out and get some water, that's okay. But this is important because this is who we're seeing. So we're going to take a step back and just think a little bit about the neurobiology of this and what's sort of driving that. Right? Stress of itself is not bad, right? It's how we learn, it's how we grow, how we get stronger. But when it is so overwhelming or so unrelenting that there's no chance for recovery, it leads to this more sort of pathophysiologic cascade, right? You go from stress to toxic stress. Resilience, when we talk about trauma, we always want to talk about resilience, right? It's kind of an umbrella term for a lot of different resilience-associated traits that help somebody sort of bounce and not break, is the sort of term of art. But really helping people regain their equilibrium after sort of some sort of major stressor. And there are a lot of arrows here. The main point is that every one of the points that we saw with our stress cascade has an opportunity for intervention to help improve the outcomes for that individual as they go along. So in this context, if we've sort of made the case that exposure to trauma is nearly ubiquitous in some way, trauma or adversity, then we want to really make a distinction between trauma-focused treatment, which is really about addressing a particular trauma directly. That's focused on resolution of the trauma-related symptoms, and in that context may require detailed trauma history. Very different than a trauma-informed approach, because that is focused on optimizing engagement. And there are these 3 components, right? Universal precautions, universal trauma precautions, universal framing, avoiding retriggering, and then recognizing this, depending on your role in the context of care, what that looks like is going to be quite different. And so we'll spend a little bit of time first thinking that through, and then later we'll sort of look at some examples. So fight, flight, freeze, the sympathoadrenergic stress response. I think we simultaneously have the HCBA Access lecture happening that is kind of relevant, and I think we hear about a lot. Does anybody know what the 4th F is? Fawn, right. So there's the fight, flight, freeze response, and there's also, for many people, this response where they will do anything they need to for you not to think they're a bad patient. They will do what they need to. They will answer whatever question you ask them because they're trying to be a good patient. They won't complain about symptoms because they're afraid that you think they're complaining, right? So we want to think about framing things so that we're reporting symptoms because that helps as opposed to complaints. We want to think about what are we asking people to answer, because is it satisfying our curiosity or is it going to directly impact the clinical care that we're about to give them? So we talk about the sort of fight, flight, freeze response, right? I think I'm not going to spend as much time on this, but just to kind of remind us, we've got that. We've got the cortisol, the sort of HPA axis and that cascade where we want there to be a negative feedback loop. But again, sometimes it's so unrelenting or so overwhelming that that doesn't kick in. And the third domain is also we're learning more and more about the ways in which chronic stress impact your health and chronic disease, including that when you have this activation of the sympathetic nervous system, there's this progenitor release from the bone marrow of pro-inflammatory monocytes that produce the cytokines that can drive things like atherosclerotic inflammation. So it's not just behaviors, right? It's not just somebody not having a great diet. There are a lot of other variables that are contributing to how they're presenting. And this is my favorite slide in the sort of understanding of the neuropsychiatric dimensions of trauma-informed care. We're not going to go into the neurocircuitry, rest assured. But if you think about these 4 categories, emotion regulation and executive function are in some ways kind of inversely related, right? If somebody is emotionally dysregulated, their executive functioning is not going to be optimal. And if you have somebody dysregulated in front of you, your work is to help them re-regulate. And if you recognize that they're dysregulated, your work is not to sort of talk them with logic out of that, but rather to sort of understand what we can do to re-regulate. And also understand that we're not seeing them at their best executive functioning. And so the kind of conversations that we want to have in terms of health discussions and so forth, it may not be the moment to do it. And so really kind of thinking about it in that way. The second is threat salience and detection. And this is sort of driven by some hereditary factors, but also life experience. So what is neutral to one person may be very anxiety-provoking or other, triggering is the word we're using and overusing at the moment, but it can literally, in this context, be very triggering. And so we need to be thoughtful about what we're saying, what we're doing, what the environment looks like, and understand, again, that we have to just continually have humility about what may seem neutral to us and not neutral to someone else. Fear learning, just a reminder that there's a very special place within the amygdala where we remember the kind of most emotionally charged things. We think about this for our patients, but also for ourselves. You've done 25 things right and 1 thing wrong, and you go home and you think about the 1 thing wrong, right? We want to sort of remember that there's a driver for that. And if we can reframe some of that into ways that like, okay, how can I do it better the next time? How do you sort of reorganize in a way to do that? And part of that is contextual processing. And I think this is absolutely kind of core. So contextual processing speaks to this ability to integrate all the different variables around the time, the space, the context of where something happened. And healing from trauma also requires this contextual processing. Because sometimes when people have severe trauma and PTSD, it's like time stopped. Something triggers them and they feel like they did 25 years ago, even though the context is now different. The evocative way of understanding it is if you're walking in the woods and you see a bear, you run, right? That's how you survive. It's an appropriate response. But if you go to the zoo and there's a big plexiglass and you see the big bear and the mama bear and everybody's running, chasing each other, hitting, whacking, and you can say, oh, look at this. You can be curious, you can be empathic, you can engage. But if every time, notwithstanding all the plexiglass, you feel as though the bear is coming at you, you respond in that way. And that is a way of kind of remembering, as people are walking into a clinical space, quite often, this is part of what they're sort of navigating internally. Interestingly, for those of you who like this stuff, contextual processing happens during REM. For REM to happen, the locus coeruleus needs to turn off. So when we think about the importance of sleep and the ways in which sort of poor sleep ends up adding to vulnerability and all the hormonal pieces that drive whether we're sleeping well or not, you can sort of see some of the points of intersection in this work. The other thing, again, we're not going to go into the PTSD diagnosis per se, but when we talk about trauma, many people have trauma and adversity and do not end up with PTSD. It is not an inevitability. And ensuring that people walk away understanding that, we talk about this because we want to intervene. To have a PTSD diagnosis, you're really having symptoms in all of these 4 categories. That's the kind of more classic nightmares, avoidance, negative alterations in cognition and mood, and sort of being able to project a sense of yourself into the future. And these arousals and reactivity, right? The sleep disturbance, the hypervigilance, hyperstartle. And these happen across different timeframes, and they have a functional impact. So what we tell people is that, when you heal from from this kind of trauma, it's not that you're not going to have the memory of it anymore, which is actually a fear people have. Right? It's actually just that you'll be able to have it, and it's a bad memory, but it's not going to stop you in your track. It's not going to end the day for you or the week for you. That you can integrate it, you can understand it, you can remember temporally where it's happening, and then you can move on. The heterogeneity of the PTSD diagnosis is part of what I want to sort of remind people. There's over 600,000 ways to meet those criteria, if you sort of put them together. So it can look very different. It can be angry and irritable in one person. It can be very numb and quiet in another, or it can be both in the same person, depending on the context. And quite often, this is overlooked actually in the quiet patients. When they're angry and irritable, it sort of drums up a little bit more of a response. Sometimes people will say they're fine because they're quiet, and we want to be attentive to both of these kind of, and everything in between. The other thing is that this PTSD comes with a lot of comorbidity. Comorbidity is probably more the norm, particularly if it's not a single incident trauma, which often it isn't. Depression, anxiety, substance use, functional neurologic disorders, are chronic conditions, sexual dysfunction, and social isolation. And with that social isolation comes a whole host of other sorts of issues that can come in, even just people who become more withdrawn and move less and then have all these other physical symptoms alongside it. So now we think about these three examples and we think about how they're presenting. This woman who presents with dizziness, she looks guarded. She's a limited historian. What does it mean? How do we understand it? Oh. The first thing I'm going to emphasize is that the first thing we should do is make sure we get a good medical history. Work it up if we need to work it up. We know that patients who have any kind of history of mental illness in their chart, they don't get worked up as well. So the first thing we want to do is make sure they are getting parity in their medical care and their medical workup. That's the starting point. But then, you know, how do we help them engage in that workup? And we'll talk a little bit about some of those techniques. But guarded and a limited historian can mean many, many things. And we'll want to sort of take apart a little bit of what that would be. The 60-year-old non-English speaking woman, she's getting agitated. What does the agitation mean? I was sort of left with a strong impression. I was called down. I was doing consults in the emergency room at one stage, and I got called in for a young woman who was in her 40s with psychosis. And she was there. She was sort of in the corner. She looked trapped. And they were, you know, and the first thing was, you know, well, why does she need to undress, right? They needed an EKG. Does she really need to take off all her clothes for the EKG? Did she understand why she was being asked for an EKG? Because she came in with abdominal pain. So we sort of took a couple of steps back. And in speaking to her, in that case, we were speaking in Spanish. We were explaining, we were finding out what the issues were. We were turning out that maybe she doesn't have to take off all her clothes to get this exam. And then it turned out she had been trafficked. That's how she got here. So she had a lot of reasons not to trust the system. There was no psychosis in that context, but there was tremendous fear. And with the fear, thought disorganization, and with all of that. And so, again, there can also be psychosis, and you want to identify that. But we need to be able to sort of take a few steps back and, you know, go through all of those steps to make sure we're covering those bases. I'll end the 52-year-old woman in DKA. So I was in bed in the medical ICU for 2.5 years as the psychiatrist. So I would round with the team in the ICU. And what was really interesting is patients who come in DKA, what's the usual discharge? Like they talk to dietary, which means making sure they know how to use their insulin, right? Case after case after case, these were patients with significant trauma histories. Often, you know, it was easier to sort of go into DK and go into the hospital than be trafficked. The household environment was chaotic. There was a lot of other things going on. The effective care and discharge of this patient was going to require something other than teaching them how to eat their food, which they know, right? So we want to, again, be thoughtful about it. I work with a group of people that we've been looking at the long-term outcome of physical injury. I was thinking as you were talking, Dr. Watanabe, my favorite proverb is, if you want to go fast, go alone, but if you want to go far, go together. And this work is always the work of groups and great groups. And for the trauma-informed care work, Annie Lewis O'Connor and Eve Rittenberg at Brigham are great partners of mine in doing that. And in this work, the team around what's called the Forte Group. It's actually the Center for Surgery and Global Health. And we were looking at, it seemed very important to demonstrate that most patients don't only have PTSD, right? We have to think in a more dimensional way, transdiagnostic way about it. And then we sort of looked at all the data for our medical system for sort of over 7,000 patients who got admitted with DKA. 2/3 of them had a concurrent psychiatric disorder that was already diagnosed, that was already in the chart. And so, those patients were likely to have multiple admissions, renal dialysis, a lower age of mortality. There are sort of these long-term effects. And the next step is to actually think about what kind of screening, what kind of conversations should we be having with these patients. So in this context, we have worked toward, and it's medicine, so it takes us a few decades to go from the ACE study, where we know this dose-response relationship is happening, where we know that there's this sort of very high rates of exposure, to practice. And we still have a long way to go. But the paradigm shift is from what's wrong with you to what happened to you and how is that impacting your health and well-being. So the trauma-informed approach, we sort of think about 4 Rs and 6 principles. And the 5th R is resilience, because again, at the end of the day, the goal here is to help support resilience by realizing the widespread impact of trauma. We get pushback and say, this should be resilience-informed, this shouldn't be trauma-informed. There's arguments for that, but I would say that unless and until we acknowledge the trauma that's happening and are sort of thoughtful and proactive in addressing that, we're not able to create systems that are going to be safe and engageable for our patients. So we want to recognize how it affects all individuals, and again, not just our patients, us, right? You pick a room, 2/3 of us have endured something along these lines. We want to fully integrate that knowledge, those 4 squares of executive functioning and emotional regulation. All of these dimensions are things that we want to be thinking about in the ways that we design our workflows, our clinics, and our care. We want to resist re-traumatization, and this requires an organizational culture. I provide a training on some of the basics of trauma-informed care, including that picture of the brain, to our front desk staff, as well as our trainees, as well as our attendings, because that's the first stop, right? The first touch point in clinical care. Our community health workers, they are engaging with patients. They bring their own histories. We want everybody to have a shared point of reference so that we have a way of maintaining empathy and understanding, and then also coming up with some good strategies to be supportive. So here are the 6 principles. The first is safety, and again, not just physical, but also psychological. In the healthcare setting, that sometimes means that somebody needs to know that they're not going to have to tell their trauma history all over again for an appointment. Sometimes, as you start an appointment, you can say, I see from the chart that you have a trauma history. I want you to know that we don't need to go into those details today. If we can talk about as much or as little, or if there's something specific to what we're going to be talking about. You can often just see somebody relax in the room around that. And even better, sometimes you ask your patient, if you're referring them, do you want me to just let them know that you have a trauma history so that you don't have to even get asked? And oh, please, that would be great. Right? The number of patients I've had who said, I was going to turn up to that appointment. I woke up in the morning, I was going to do it, and then the prospect of being asked about that again was just too much. I just couldn't walk in the door. And so, again, the more that we can think about how do we create physical and psychological safety for patients and for clinicians, right? People, if they're worried that they're going to get triggered the second they walk in As if a clinician is worried, they don't have the bandwidth, they don't have the wherewithal today to see somebody who looks like their grandmother who is currently on hospice and is sort of feeling their own dysregulation. If they don't feel like they know how to regulate, there's going to be a lot of absenteeism. There's going to be a lot of inadequate care. So that sort of self-awareness, the ability to regulate, the ability to sort of titrate to tolerance is a really powerful one. Transparency really is there in service of trustworthiness. We're asking people to trust us very quickly with very sensitive information. And transparency can mean anything from being really clear and explicit about how you're going to use that information. And I think this discussion about whether there should be mandatory reporting is a really interesting one and complex. But people should know, because if you've told them that, if I understand that there's imminent danger to a child or to you or to an adult, then I have to report. And then they tell you, that's very different than them sort of opening up a bit without any understanding of where that was going to go. Same goes for documentation. Have I just been pushing this slide as in my enthusiasm? Transparency of discussion of where the information is going to go, of how it's going to be documented. Collaboration and mutuality. This was, it used to be the very unidirectional. I'm going to tell you what's in your best interest, and then you can do it or not do it, right? We've seen a lot of good trauma-informed care in the substance use world, where they understand harm reduction and motivational interviewing are really essential parts of the ways in which we care for patients. But that is equally applicable for all sorts of other contexts and populations. And so, again, when you think about emotion regulation, executive functioning, to have a real collaboration, you need the patient in the room to really be able to engage. You want to think about what are the choices that we can give them that are real choices, not choices that they can't actually use. And then how do they feel empowered actually to ask or to sort of say? Peer support, there is something about lived experience that is different than what a clinician can provide. And so we always want to think about that. And we make it explicit because if we don't and we're busy, it doesn't get put into the treatment plan, right? You sort of say, oh yeah, and I can connect you with this national organization, this international organization, this local group of survivors, right? We want to make that as categorical. And we recognize that people have intersecting identities. So sometimes this peer support is around survivors of domestic violence. It's around, diabetes. It's around their pathology, their illness, their distress. But sometimes it's also around some of their interests and skills and joys. If it's dancing or music or knitting or whatever else it is, to remember that we want to see people in all of their capacities. And that becomes really important in trying to care for patients with this much vulnerability, because if we only see their vulnerability, then it's really hard to let them walk out the room. You feel you're holding so much, but if we can identify they were somebody who had all of this capacity before they walked in the room, so what are they walking out with, and how do we help support that? And then gender, sex, historical trauma. National Trauma Council has also phrased this or rephrased this as cultural humility, which I really like. Gender, sex, historical trauma. It's never whether, it's how this is impacting somebody. It's the how. And we don't know how until we ask. For some people, their religion is a source of strength. For some, it's their source of trauma. For some, their culture is a source of strength. For others, a source of trauma. We have to just stay curious and find out what it is for the individual in front of us. So we can apply these 6 principles to the patients, to our clinicians and staff, to the healthcare system. I think I want to move to thinking about how you translate this to engage trauma survivors in healthcare services. So the settings and contexts really matter. If you're meeting somebody in an emergency room and you're trying to sort of just decide what's happening next, what's the differential, what do we need to work up? On the psychiatric side, we want to figure out their safety and where they're going next. If you are clear about what your role is, and the patient is clear about what your role is, it gives you a lot of data and it's sort of a container. Because if you've told somebody, I'm only going to meet you once, I'm trying to get the symptoms to help us know what the next thing is to do, and they start giving you their whole trauma story, that's clinical information, right, about their own capacity to sort of contain and regulate. Different than if they think that you're the person who's going to follow them for the next 10 years. And unfortunately, in a very fragmented system, patients don't often have the sort of comfort or reassurance of having a long-term provider. But these are different roles if you're a consultant, for example. Mental health services happen in many different touch points. There are community resources as well. And sorry, we just really want to think about what those next steps will be. So within the healthcare system, this is I think, mostly US issue of open notes, that patients can read all of the notes that you're putting in Epic. We try in the trauma-informed frame to really think about this as an opportunity. Documenting with patients so they know what's going in the chart. Being really thoughtful about how much or how little you put in is important. There's almost never a reason to be specific about immigration status within a note or justice involvement. But sometimes it's really helpful to mention something, as their lawyers later tell us, to be clear that there were maybe some psychosocial stressors, or to just be very neutral but clear about the injuries that they're presenting with. Again, diagnostic overshadowing and medical disparities. We want to really think with the patient in the room about what's going on with them and not bring all sorts of assumptions about them, their background, their race, their chronic conditions, their sexual history, their gender, any of those things. We really want to try and create space where they feel comfortable sharing. Role for CHW and peer recovery coaches, again, they've shown this very robustly in the substance use world, but we know that this also has a really valuable role to play for other people who are navigating complex conditions. Screening versus inquiry, this is the stuff of a whole other lecture and conference, but screening really refers to these instruments where you have a list of things that you're asking about, right? The domestic violence screener has, have you been hit, kicked, or punched? There's sort of lists. Depending on who's asking, if people know or don't know what their information is going, they may or may not provide. This screening is not always a useful tool, and we don't want to become too comfortable with the idea that, well, we did screen was a negative screen. Right. Inquiry is asking an open-ended question that allows space for the patient to say as much or as little as they're comfortable in that moment, and to sort of build trust. Do you feel safe at home? How are things going? And then kind of creating a context for that. And we can talk a little more about that later. Discharge planning, again, we don't want to call homelessness a mental health problem. But if part of the reason they can't make it to the appointment where they're doing the paperwork to try and get on that list, we want to also not minimize or ignore that. And so there's a role always for sort of screening and thinking about what's going to help empower this person. And again, providing a range of options is key. And that never letting a crisis go to waste, so sort of the telehealth access that came in the wake of the COVID-19 crisis has been actually very valuable. So the clinician perspective, it seems like we should do this. It seems like, of course, we'll ask everyone in this way. But what happens? Why don't we? Sometimes we're afraid of making a bad decision, or we're going to open up Pandora's box, or we're afraid that we can't fix it, or we're frustrated because this is just not working in the ways that we want it to. And we have to re-emphasize that just bearing witness, creating space, validating the distress is an intervention sometimes. You're not the person who's responsible for taking them in and getting, managing all of their issues, but you are starting to create a space where they can start to think about those. And that is a really important component. You may not get everything done that you want to get done, but if that patient comes back, they do a follow-up appointment, that was a win. And we do need, as a sort of system, to be sort of thinking about that and valuing it. So 3 steps for optimizing engagement. One is this universal precautions, universal trauma precautions. Assume everybody survived some adversity and inquire about the impact of the trauma instead of the trauma itself. Universal framing. This is so important and much harder than it sounds. You know, a classic sort of visual for me is we'd be rounding in the ICU and we'd say what you're going to do before you do it. Oh, of course, of course. And then they would walk in, the residents would surround, one gown would come off, the stethoscope goes on, the blanket comes off, a hand goes in to feel pedal pulses. Now, all of this has happened. They go, oh, we're just going to listen to your heart and make sure your pulses are there. Patient's already now been, you know, undressed at both sides. It takes discipline. It takes modeling. You know, I know all this, and sometimes I, you know, will be in a particular context and maybe skip a step because you have to really take a deep breath and make sure you're going to be intentional. Say what your name is, say what your role is, and then what's going to be done, how, and why it's necessary. And that's a really, the why is really important. You know, people can tolerate a lot if they don't feel it's gratuitous. And if you're really trying to work up a potentially serious issue, you know, somebody's presenting with a bleed and you really want to make sure that you need an exam, that's really helpful to explain it. Because there's a whole set of assumptions about, of course they understand it's important, but often people don't, and they don't know what you're going to do, and they don't know why. And the third is to kind of reiterate this critical awareness of role and context. The more that we're doing team-based care, the more we're working with both clinical and non-clinical team members, the more we're sort of thinking about what should be coming from the clinician, what can come from a peer, what can come from a community health worker. And again, it's different if you're screening versus evaluating, different if you're treating and if there's a procedure that's part of the treatment or a medication that's part of the treatment, or if you're just responding to a referral. One thing that you can do is know your local resources. These are some hotlines that may be available. These are sort of national ones that may be helpful for those in the US. But you're going to feel a little more comfortable asking a question if you have an idea about what is one other thing that you can do. 988 in the United States, 24/7 crisis response. It's not calling 911 where the police come and take you against your will into an emergency room. This is 988, a very, very useful resource. So I'm going to sum up and then leave time for questions. There's kind of a lot of directions we can go here. But these are the sort of 3 key points. One is that trauma is highly prevalent and highly associated with chronic medical conditions, as well as psychiatric and substance-related illnesses. Traumatic exposures across the lifespan impact distress tolerance and engagement in care. But we want, in this context, to recognize that early life trauma has particular neurodevelopmental impacts, that trauma that happens, you know, across the lifespan continues to have those impacts. And we want people to really have an understanding that when they come into the room, where they land on that vulnerability to resilience spectrum is a function of where they are, right? And so patients in their 50s, early 60s, sometimes the most distressing thing is that they're distressed. They say, my whole life, I've been the person who answers, you know, everybody else's questions. I'm the source of support. I'm the strong one. What's happening now? And being able to say, you know, actually all that cumulative stress is maybe part of why you're vulnerable right now. But there are things we can do to help bring you back, right? And that's a really important, empowering message. Resilience, while not everybody is going to want trauma-focused treatment. And some people can't tolerate it, some people are not interested in it, and also we just don't have a lot of access. We need a lot more. And so what we're looking to do is really have a health system where we're trauma-informed in all those ways. And then as an engagement strategy, you know, when things are intense in some way or other, I do it because this is what I do, but I encourage others, is you take a step back and you just walk through the 6 principles. Do they feel safe? You know, is there trustworthiness? What other thing do they need to know to feel like there's some transparency? What would collaboration look like here? Are there peers that we need to engage? In what ways are their culture, race, ethnicity, historical background, how is that impacting what's going on right now? And is that something that we need to call out and address? So as next steps, really just educate yourself and your patients about the fact that these do play a role. Again, not in a fatalistic way, but in recognizing these are risk factors just like others, just in the way that there are also resilience factors, right? And again, we want to think about those alongside. You want to consider what barriers may be impacting the patient engagement around a particular workup, and what might best support a patient's resilience. And we'll talk, I think, in the panel with some real more examples about language we can use. So I'll sort of leave it at that. And then we want to think about health system and community-based resources. We want to optimize patients' choices. We want to think about that support across the lifespan. We want to think intergenerationally about what else is going on. Sometimes women at the sort of stage of life of menopause are now being asked to take a lot of responsibility for their grandchildren, for example. And there may be a lot of different reasons why they're ambivalent about that, or scared of it, or having issues with that. If we don't ask, we won't know. And I think about the sort of data being golden. It's also patient data. Like, what do we need to know about what's going on? And I wouldn't sort of, those checklists are often not inclusive enough. Another big one that comes up for me, and again, I'm seeing patients in a psychiatric setting, people have incontinence, and they've been incontinent for years, sometimes since they delivered their kids. There is so much shame around that they just never bring it up. They've never mentioned it to their GYN, to their primary care, to anybody. But now it's pretty bad, and they don't want to go out. They don't want to sort of engage with all sorts of things because of this issue. And it's just never come up. So really being able to think holistically about what are all these different drivers. If shame and guilt are getting in the way of somebody being able to report symptoms, then we want to create a space where we neutralize that, right? We create a safe space where we can talk about anything. We normalize that these things come up, and we are then able to really help get people connected to the kinds of things they need at that moment in their lives, and as they go forward. I would say that sometimes we have to just come to terms with the fact somebody's going to come in, they're going to share some things, we're going to give them some resources. They're not going to necessarily say, great, like, let me go do this DV resource, leave a shelter, don't know where my kids are, don't know what, like, that's not the sign of success. That is not our goal. Our goal is to give some resources that she can start to think about, start to plan, know who to call for more information when she feels safe doing it, and come back and have another conversation, another meeting, follow up. If you're referring them for some consult or for a procedure, to turn up to that procedure. And the more that we can sort of use that engagement and optimization as part of the ways in which we count the value and impact of our work, the more we can feel actual gratification that we've done something in that session, and the more I think that we'll see our patients get better. So I'm going to stop there, and thank you for your attention. Lots of references.
Thank you, Dr. Levy. Carrick, I want everyone to know that we have a different Slido. So if you'll get this QR code, and especially if you're going to stay after the break, this is where you ask questions. And for the people in person, I can allow you to ask some questions in person because this might not have been clear. But for everyone online, please get this QR code. It's a different Slido than what we had this morning. So if anyone wants to take the picture, ask some questions, and this is the same QR code we'll be using after the break for the panel. So if you could please pay attention, or is there any way to keep that up longer, Katie, or somehow keep it on screen?
Look forward
or on
to
the
your
bottom
questions.
or someplace. Anyway, Does anyone, and I just have two quick questions, and anyone in the audience, if you can give us a question if you like, and then during the panel after the break, we can have it be a little more interactive. But can you just give us a really, I know this could be like hours and hours of talks, but so first of all, we know there are domestic violence and trafficking patients in our practices, and we don't know who they are. And so I know it's a big topic. And we have a recorded talk on this as well. But can you just let us know for primary care outpatient doctors, what are some things that we should be thinking of, or any way to, besides obviously universal trauma-informed care, but what advice do you have?
I think there are a couple of things. One is, it is kind of going back to the basics. And when you hear somebody who's having difficulty giving you a clear history, you want to sort of, that can be a really important marker of it's a marker of something. It could be that they're anxious and they're dysregulated and they can't remember. But usually somebody can give you some level of history. And sometimes when there are gaps or when there's real vagueness, that's an opportunity to say, sometimes it's hard to give a full history when there are parts of it that you don't feel safe sharing. Are you ever, and so that's one piece of it. Another piece of it is actually just saying, is being clear about whether the environment that you're interviewing them in is safe. So this comes up in telehealth. You don't know who's in the room, you gotta ask, and you have to sort of say, is it okay for me to ask some clarifying questions? And if the patient says, no, not really, then the answer should be, okay, let's try and get you on site for a visit, right? If a patient is there and there's someone else in the room, it's a practice that we usually say, one part of our visit always has whoever's there, you want to get them out of the room. You're not going to ask these questions with someone else in the room. And when that person is out of the room, you have an opportunity to say, I want to give you an opportunity to share anything that you feel would be helpful in taking care of you. And you can also say, every patient that I meet, I give some resources to about safety. Every patient I meet, I tell them about, and you pick your local resources. Some people want to put that in their phone. Some people don't. Some people want to call it pizza and put that number in their phone. But you want to create a safe space in which you can then explore and provide some resources. You want to, in those contexts, it can be really helpful to screen for safety. We know that risk of suicide is higher. We know that people have seen often a primary care clinician or other before they've made some sort of attempt. And so again, sort of saying, sometimes when people are under a lot of stress or they don't feel safe, they have thoughts of taking their own life. Have you had any thoughts like that? That's another kind of space that we don't want to skip in this discussion. But I think that kind of careful history taking and then looking at the sort of pattern of injuries can also be, in certain contexts, really important. And Bharti Khurana is doing some really important work at Brigham looking at, started out as radiologic patterns and sort of now sort of using the sort of health record to get these risk profiles and really trying to understand, if you tell somebody, just like other people have chronic medical conditions and we see risk factors, I'm wondering if there's any issues that we can talk about to make sure that you're feeling safe, and if you're not, that I can give you some information that might be helpful.
Thank you. That is actually helpful for us. So one last question, and then we'll go to break. I also want to ask folks, we're going to not be using these back doors very much afterward because of but we do have other egress. Anyway, what in just a real bird's eye view, I know this could be a few hours of lectures, I'm sure its own conference. but how would we explain to our patients, like say we identify that there is a trauma history, they bring it up or we suspect it, and they ask about, we say we're going to refer them. Can you just give us a real bird's eye view of what their trauma recovery, what kind of, what tools would be used for that, what kind of modalities, sometimes you have to know, like.
The 1-minute version of PTSD treatment and recovery.
No, but if we're
Yeah.
referring someone for alcohol,
Uh-huh.
inpatient rehab, we want to be able to
Yeah.
say what that might be like, just very.
Sure.
quickly.
No, there is a good 1-minute answer,
Oh, perfect.
which is that there's sort of two components to this. One is different levels of care. So there's inpatient psychiatric care, but there are also partial hospital programs or intensive outpatient programs that people stay in their homes, but they spend more of the day. It gives a lot of structure. That's a really important level of care for people to be thoughtful of. So partial hospital programs, usually 5 days a week. The next step is intensive outpatient, which is often maybe 3 times a week, and some of those are after hours if people want to go back to work. This is a way to continue to support them. And then there are different kind of levels of care, team-based care, or sometimes it's individual medication therapy and group. Each of these domains are really important. So you sort of can start up at the top. You can also come in. So you're just doing an outpatient referral. Somebody's had this. There's medication. There is therapy. The highest sort of data is the combination is what's most effective. But therapy is really essential. The medication is there to help regulate the anxiety, the depression, some of the PTSD, irritability, anxiety, hypervigilance, that allows people to then engage in the therapy. And there are a series of evidence-based therapies that can be around sort of trauma-focused treatment. There's cognitive processing or CBT, DBT, because there's a lot of distress tolerance that kind of cuts across some of these populations, and sort of having a framework for learning distress tolerance skills in this transdiagnostic way can be really helpful for folks. EMDR is another modality that's sort of a more somatic therapy that we think about. And for some people, you're really starting with behavioral activation. STAIR is another modality, but the starting point is people need some self-regulation skills, some sort of mobilization to be able to then do the work of exposure. But it's really, I'm glad you asked the question because it's really important that people understand that there are treatments and they're very effective treatments. It's different if somebody has a single incident trauma, it's never good, but like one rape, one car accident, one thing. That is different sort of than somebody who has polytrauma. They've had trauma there since they can remember. And that can take a different sort of set of treatments to help stabilize. We often try and tell patients, like, sometimes what you've done was super adaptive to get through your trauma. So it's adaptive, and then it becomes maladaptive because those things are not working in another environment. And sometimes in health, it's like ignoring a lot of stuff. Like suddenly all that stuff comes back and now you're in your 50s and it's all there, right? And so sometimes that can be really helpful for patients because it's sort of at least giving them credit for what they have done, right? That was a strength. They kind of got through to where they are. And usually by the time they're asking for help, they know that it's not enough, it's not working. So what else can we do? And you're not asking people to kind of give up what they think is working for them without adding something that's a good alternative. Hope that.
Yeah, that's great. We'll go get a coffee or something, guys, a snack, if you would. And if you're coming back, please, we're going to address questions in the next hour. So come on back in about 10, 15 minutes.